Hi, today's case is the 15th case, and this is a patient who had mediastinal fibrosis, so the diagnosis right away. Uh, this is a 36-year-old man with swelling of the neck and face for a year, and this is how he presented with the plain scan here, the contrast study, there's encasement of the SVC, which is why basically there was facial swelling, and we can see the chest wall collaterals here. And it's just have a look at the slightly increased density or the hyperdensity that we have on the plain scan. PET-CT had been done earlier, and this didn't show any uptake because the initial working diagnosis was of a malignant mediastinal tumor. So I biopsied it using an extrapleural approach, and the diagnosis was mediastinal fibrosis. During the biopsy, the lesion was quite hard and gritty, but unlike in other situations, it was not rock hard and the needle did not bend. There was no IgG for disease, negative microbiology. So mediastinal fibrosis has two distinct patterns. One is the infectious, post-infectious that typically occurs with tuberculosis in our country and with histoplasmosis. And then we have the inflammatory mediastinal fibrosis that is actually reversible as well. And so that occurs with IgG4 disease and can be idiopathic and is often associated with retroperitoneal disease or multifocal disease. So let's look at the infectious, post-infectious, because that's actually the commonest in India. And so we'll get a soft tissue mass with vascular and bronchial encasement, especially venous vascular, typically a young patient less than 50. By the time the patients actually get a diagnosis, it's been a long time. No uptake on PET unless we pick this up in the acute phase. These are T2 dark, hyperdense on plain CT, hard on biopsy. And if there is pulmonary venous involvement, we'll get a dysplastic looking lung with septal thickening. And not all findings occur in all patients. So let's look at the infectious, post-infectious setting. Now, I had shown this case about I think 7 or 8 weeks ago, when we were looking at a 22-year-old, with a left hilar mass involving the bronchus artery and vein. I remember that video was titled "Do Not Neglect the Plain Scan." And so here we see the soft tissue mass, there's bronchial involvement, the pulmonary artery is involved, and the inferior pulmonary vein is involved as well. The left superior pulmonary vein was spared. And it looks aggressive. The working diagnosis was a malignant tumor. The PET showed activity. There were two biopsies done which were negative. There was a lot of inflammation and a little bit of fibrosis, but eventually a diagnosis of histoplasmosis was made on the biopsy, and the patient had a history of travel and short, medium term stay in the United States. And so all of that came together. And with antifungal and steroids, the patient improved dramatically. But what we did find when we went back to the images was the hyperdensity on the plain scan. And this had been missed, including of the subcarinal lymph nodes. But if this had been picked up earlier, it would have fitted in and allowed, let's say, a better confidence in making the diagnosis initially. So when we should look for this hyperdensity, and if we use 3 or 4 millimeter MIPS, we can see that much better, and you can see that on the coronal scans. And the lesion was T2 to intermediate dark, a little bright on the stir images. And here's another patient. I biopsied this patient in June 2016, and and I don't have the images from there, but sorry, it was 2015. And 4 years later, we can see that the SVC continues to be narrowed. The lesion shows minimal enhancement. While it's not completely hyperdense on the plain scan, there's a lot of calcific foci here. And when I was biopsying this lesion, it was hard. And I'd used an 18 gauge at that time to do it, and the diagnosis had just been non-specific fibrosis. Here is another patient, unusual presentation. In February 19, there was some post-infectious, or rather post-obstructive infection. And we can see some calcification here obstructing the bronchus, and then there's post-obstructive atelectasis. The MIPS show the narrowing of the bronchus. The subcarinal node is a little hyperdense as well, so there's arterial involvement, the left pulmonary artery, and the left superior pulmonary vein. But again, if when we MIP these images, you can see the diffuse calcification of the soft tissue that is producing the bronchial and the vascular narrowing. And this is again mediastinal fibrosis with post-obstructive changes. This is a 34-year-old biopsy proven. The mass was encasing the right inferior and right superior pulmonary veins. Um, and you can see the septal thickening because of the pulmonary vein involvement. But over a period of time, there is volume loss and the lung starts looking dysplastic. So, along with the septal thickening, there are these reticular opacities that start appearing. And this is something we've been seeing consistently now in many patients. So here is a 23-year-old who had tuberculosis in July 15, left pleural effusion, aspirated, put on antituberculous treatment. June 17, we can see the volume loss, and November 19, the pulmonary artery has become larger. And because of that, the patient got investigated. Um, and there was a CT scan, which I don't have, that showed that the left pulmonary artery was narrow and there was abnormal soft tissue. So she came for a PET CT, and you can see the large MPA and this abnormal soft tissue that showed minimal uptake. And then when we put everything together, clearly this was mediastinal fibrosis. But look at the lungs. There is volume loss, there is septal thickening, and there are these reticular opacities which have occurred because of chronic, long-standing obstruction of both the pulmonary veins and then the downstream effects that have occurred because of this. Another patient, 63-year-old, who presented with breathlessness, has just dense calcification in the mediastinum, right hilar, and subcarinal regions. There's complete narrowing or involvement of both the pulmonary veins on the right side. So the right inferior is gone here, the right superior is gone here, the right pulmonary vein is completely encased as well. Um, and again, if you see the lungs here, they're completely dysplastic looking. There's not only septal thickening because of the downstream changes from the pulmonary vein obstruction, a little bit of pleural effusion, but there are these reticular opacities that have developed over a period of time. So those were the post-infectious mediastinal fibrosis, typically hyperdense on plain scan or with actual calcification and then bronchovascular involvement. And then we have the inflammatory fibrosis, which is commoner in the Western countries, simply because uh, you don't have enough post-infectious mediastinal fibrosis there. This is potentially reversible. The post-infectious mediastinal fibrosis is not reversible. This may be reversible. Again, there is vascular bronchial encasement, again, typically young patients, but shorter history. There's usually uptake on PET, on MR. The lesion can be T2 intermediate or dark and gritty on biopsy, but not hard. So this is a 49-year-old who presented with cough, and there is this abnormal soft tissue in the left paratracheal region involving the tracheal wall, thought to be malignant slash lymphoma, but it was dark on T2 on the MR. And that led to the possibility of this being fibrosis. Anyway, went ahead and biopsied it using an extrapleural approach. And this turned out to be a combination of inflammation and fibrosis. The patient was treated for this, IgG4 negative, And the lesion actually significantly regressed after about a year and a half. And the patient actually came for a PNS CT and then said, let me just get the CT chest done to check what's happening. So this wasn't even a scheduled follow-up. Here's another 45-year-old who has retroperitoneal fibrosis or periaortic abnormal soft tissue with a large soft tissue mass here. Now, when we look at it first, we would say this could be lymphoma, perhaps an aggressive thymoma, less likely. The working diagnosis would be lymphoma. But the moment there's multifocal disease like this, then this is likely to be an inflammatory process, and this again on biopsy showed a combination of inflammation and fibrosis. Was IgG4 negative, but it could have been IgG4 disease. Unfortunately, I don't have follow-up of this patient. So in any case, just to summarize, this is basically mediastinal fibrosis, two major forms. We have the post-infectious, where we have hard, gritty masses that produce bronchovascular involvement. And when the pulmonary vein is involved, we get downstream volume loss, reticular opacities, and septal thickening. And then we have the inflammatory mediastinal fibrosis, which is like retroperitoneal fibrosis, typically resembles what we get with IgG4 as well, or the idiopathic forms, which are potentially reversible and show uptake on PET. So if you have any comments or questions, do email. You can subscribe if you'd like to receive updates each time a new post is up. That's the book. And I hope you've enjoyed this. Thank you for your attention.